The next speaker, who's Beate from Health Technology Assessment at the Institute of Health Policy Management and Evaluation at the University of Toronto. Beate serves as an expert on economics of infectious diseases to national and international advisory bodies, including Canada's National Advisory Committee on Immunization. And she also chairs the Economics Task Group and co-chairs the Economic Guidelines Task Group. So she will talk to us about Ontario Modeling Consensus Table, mobilizing modeling expertise to inform policy decision-making.
Thank you, Jack, for the introduction. Thanks, everyone, for having me here today. I'm really excited to be here. And it's actually perfect kind of following Nick's talk. So I will not speak much in terms of kind of content or like in terms of insights from modeling, but more about structures and processes and kind of how we build the modeling consensus table, its role, and how kind of the relationship with decision makers works. And maybe lessons learned basically of what we can keep, maintain, or transition this to a more longer term setup. I'll start with my key messages. Basically, we all know now we are in a pandemic, and so real-time pandemic planning and response is basically really rapid decision makers under very high degrees of uncertainty. And so what this requires in terms of modeling and kind of lessons learned is that it's very much an iterative process. So we start with something more simple and then keep building on and on onto those models. Also, perfect is the enemy of the good. And I think we all learned that we cannot model the same way we would usually do that. We won't have the time, we won't have the data. And there is a decision maker kind of literally waiting often for this type of evidence to support decision making. To forge kind of those relationships, I think it requires a very high degree of trust and collaboration. And it's very, very strong linkages between scientists and policymakers. And ideally, those kind of linkages are built way prior to any kind of emergency. So that's something that should be ongoing, and those linkages should exist all the time so that we can build on that and mobilize and capitalize on this if there is some kind of health emergency. The other thing Nick touched already on is data. So have easy access to all the data that's needed or that's critical for the modeling needs to be available to the modeling team. And then finally, I think that's very much the Ontario lesson learned as well, is that having that consensus, building consensus around modeling predictions and having this collective lens is very well suited for policy decision making, especially in an evolving pandemic. So in terms of policy decision making, how the science fits in, on the right hand side, you see kind of the chart of how the different kind of committees and tables, in Ontario we call them all tables, so they're all kind of different tables that were put in place in the very beginning of the pandemic. That's an early slide, I think early 2020. It changed over time and changed quite a lot. And so at some point there were even more people and tables and groups involved. And I think it kind of scales down now. But overall, it's very, very complex decision-making, policy decision-making process. And so there's, of course, a need for credible data on the epidemiology in terms of modeling that would inform policy. And so traditionally, prior or outside of a health emergency, what usually would happen is that research is commissioned to most often individual academic groups or consultants or, you know, the individual group or individual scientists. And that, in my view, is not very well suited in terms of guiding policy when we have this rapidly evolving pandemic or process of things happening. And it's because a single model kind of cannot take into account the structure or that are needed. So each model, you know, has its taking different approach. And so in terms of high uncertainty, those different approaches would cover a wider range. And so that does not only relate to data, but also to the model structure. So there are different components that lead to that. So having one group informing policy decision-making in this type of scenario is not very the best approach in my view. And so what Ontario has done in terms of mobilizing scientific expertise, Ontario started what's called the modeling consensus table in April 2020. So it was very, very early. From the get-go, it had a broad range in terms of memberships, scientists across different fields, mathematics, epidemiologists, health services research, behavioral sciences, all very broad range in general, from universities from across Ontario. We also have public health and health practitioners and clinicians, as well as senior decision makers and government employees. And so trying to cover all the different stakeholders. In terms of core objectives, I do want to highlight that the objective of the table was and is to offer best guidance to decision makers and health system leaders, as well as the public. So it's a very important stakeholder in addition to policy decision makers. And so one of the ways of how this work is not only that we have everyone sitting at one table, but also that from the beginning, we implemented data sharing agreements. And that was critical, I think, and very, very attractive to the modelers in terms of joining and being on the table, other than, having this kind of policy relevance of your work, is that you had access to data that nobody else really had access to at that point in time. Again, it changed over time. So what happened in the beginning of the pandemic is that our traditional kind of data sources been very lagging. So of course many of us have access to health administrative data, but then they're in the best case, 3-6 months behind, sometimes a year behind. There's a very complex process in getting access to the data and getting it analyzed and so on. So basically creating a portal into which the Ministry of Health would basically put data, and they update that data, they update this daily, and scientists can download it and use it for the modeling, was really, really important. So there are some conditions related to this, so can use it for our research. If we publish any data or any research coming out of using that data, we will inform the Ministry of Health 24 hours before it hits kind of the public domain. But otherwise, that's basically it. And we have ethics approval already in place for the University of Toronto as well. So it's basically a very, very easy process. So we got basically rapid access to case counts data, or the whole database that collects this type of data, and now testing data and all kind of other data that might be important for modeling. So that's been very, very key. And then in summer 2020, the science table started, and at that point, the modeling consensus table became a partner of the science table. So what we're kind of doing is basically, several academic teams that have developed models. They run those models for our regular analysis and for specific questions that may come up. All of the models that we use have been presented to the modeling consensus table, often multiple times. There are several iterations of those models, and by now most are published in the peer-reviewed literature. We have covered different model types. It's a very wide range. Compartmental models, some especially in the beginning were not age-structured, later age structure was added, and so on. Vaccination was added, so kind of features kind of this incremental kind of development of different models. As agent-based models, there are other more simple forecasting models. For the most part, the models that we run are transmission models that predict case count, but also hospitalizations, some ICU admissions, and some also predict death. And we have one specific model that looks at acute care system. So what we have done for most of the pandemic is bi-weekly updates. And now we switch to something that's more every 3 to 4 weeks. But for the first year, we have done very regular bi-weekly updates. But basically, we're looking at all the predictions across the different models, usually from 3 to 5 teams. And each team is running a whole bunch of scenarios. We select the case predictions that we think are most reasonable and reflect the situation where we are in and kind of cover the uncertainty very well. And then usually what we did is running those case counts or case predictions through our acute care system model to estimate ICU occupancy. And then every now and then there would be very specific questions, as for example, a new variant of concern, questions around testing, how should we organize testing in schools, for example, how should we roll out vaccination, questions around ventilation, all kind of other things. And so those are often specific questions that are taken on by 1 or 2 models, by modeling table members who have a model that can easily or that can reasonably easily be adopted to address that specific question. And then some of those questions became more permanent, like variants of concern or vaccination, and then was integrated in all the different models. And so if there are specific topics of interest where we may not have quite the expertise or the model, we also have a presentation by guests. And I've seen many people on the call who have presented to the modeling consensus table and kind of contributed to it over the last almost 2 years, not quite yet. So here are some kind of examples of specific questions that we have looked at over time. So there's questions around school opening. So this was from, I think, September 2020. We could show that school opening for sure has an impact, but it's not as large as people seem to believe at the time. Is on the right-hand side, really interesting work, which has been very, very basic, but very interesting in terms of communicating also to the public, which that is a very important stakeholder, how it works when cases seem to kind of decrease, but we know there is a variant of concern that is more transmissible, and you can't say, well, eventually it's going to take off, but this was kind of showing how this could potentially work. Because we have access to all this data, we are also able to do some analysis that are more on the epi side and kind of characterizing specific issues. For example, is a new variant of concern more severe? What do we know from our Ontario data, and how much more severe could it be? And so those are the type of analysis that are often standalone and important information in itself, but that also feed back into the models. Some issues I think that we addressed in specific questions that we addressed, I think what we're kind of really proud of is looking at heterogeneity and inequities. And so it did start with this type of heat graph where we looked at positivity rates across different age groups, and kind of continue to what you see on the right-hand side, where we looked at cases by neighborhood and organizing or neighborhoods or communities by the proportion of working population, the percentage of the population that works in essential services and lives in multi-generational households, so kind of showing inequities. And then we see on the bottom, looking as well in terms of equities, so it's kind of more from the epi analysis and not directly from the modeling, but feeding into the modeling, looking at how cases are distributed across Ontario, for example. We also looked then when vaccines were available, continuing kind of this equity teams, vaccination coverage by neighborhood risk. So kind of looking at what is the coverage in the highest versus the lowest risk areas, and there was quite some inequity. On the right-hand side, it's kind of neat modeling showing really the prevention gap. So this kind of idea of one size fits all approaches would not be an optimal strategy, because we will have those prevention gaps. And that in turn then led into us looking in what if we tailored our interventions and provided or roll out vaccination programs predominantly in the highest risk neighborhoods first. And so that was a strategy that was implemented in Ontario and was very, very successful. And that was based on the modeling work we have done. Now switching just briefly to kind of the bi-weekly modeling. The first one put out was the one I see on the top left, very, very basic. So with this point in time, we had the acute care model. And actually what we did was kind of looking at case trajectories from other countries. And thought, okay, if this if COVID would spread in Ontario the same way it spread in Italy or in South Korea, then this is what we would expect in terms of ICU occupancy. And so over time, this became way, way more sophisticated. And so on the bottom is the latest one we have published that was December 16. We're currently working on a new one, but I couldn't include it yet because it's not quite ready yet. But however, what I do want to do is kind of, this is basically how it works. I think kind of a little bit looking at what's going on behind the scenes. So generally we have 2 to 5 teams that run their models using different approaches, different assumptions, different data sources. So kind of independently doing their modeling. We sometimes kind of talk about key factors. For example, now we know that Ontario already announced there'll be some reopening on January 31st. So all the models would implement some kind of opening on January 31st. And then we meet and review. And so we kind of plot basically all the different trajectories that the different models produce into one graph. I split it here into 2 because there were so many that was from the December update, some with interventions, without interventions, and these are only the case counts. And so we kind of look at it and you kind of see already how it often kind of groups. So there's often we have kind of groups of scenarios at the higher end, at the lower end, and somewhere in the middle. And so then we kind of walk through this and pick the ones that we think are kind of are most appropriate, most relevant, cover this uncertainty. And that's what we do on Monday evening. Then we present to the science table for review and feedback. So we go there usually on a Tuesday for the first time and then kind of take that feedback into account and go back on Thursday. And in between already presenting to decision makers, and then generally the public release would be on Friday. And so that was basically what we came up with in December. So where we kind of started with this more messy type of curves. And then this is what was in the public slide at the end in terms of cases. You remember this was a tricky one, mostly because Omicron had just started. So we knew very, very little about Omicron. And of course, you know, if the release is on a Friday, then the modeling starts at least 1 week prior to that. And so there's that delay as well. So at the time the modeling teams did actually the modeling, we knew very, very little. And so we also made some assumptions around how ICU could look like if Omicron has the same severity as Delta, because again, there was little evidence at the time. What if it's 25% less severe? And so kind of looking at those different scenarios. I think I want to finish up in terms of process a little bit. So there's the science table process where we kind of produce weekly briefs and public material, things that are put up on the website. If you look at the right-hand side, it kind of as one of the partners here, the modeling consensus table I already spoke about as presenting to the science table. There are public briefings, and everything we do is published on the website. But it also goes to what used to be the health coordinating table, or straight to the Ministry of Health. And then what we also did for most of the time, our minister's briefing and present directly to cabinet, at least for the first year. And of course, transparency and communication is very, very important to us. So I think most of you will have seen our website and the information that is on the website, as well as all the media and press releases that we've done over time. And some examples of what's on the website. And I don't need to go much here. And I will finish again with the key messages in terms of what I think is important. Really what is different is that it's very, very rapid decision making under very high levels of uncertainty. And this requires a different approach to modeling than what we're used to, in terms of this being a different iterative process. And that I think we need to be very careful in kind of saying when is good enough to have an impact on policy. And can't stress enough how important consensus and collective lens is to guide policy decision making in this type of situation. So thanks so much, everyone. I also want to thank Kumar is here, the former co-chair of the modeling table, and David Ernest also here, who is the current co-chair of the modeling table. So I'm presenting on behalf of all of us. And of course, Peter is here as the scientific director for the science table, and many, many, many members of the modeling table. So it's really amazing to see you all. Thank you.